the operating room, it's in the back of your mind, and you're not making decisions properly. So in summary, I'll just conclude here that a lot of these mistakes are occurring to human factors. And we need to remember that iatrogenic vascular injuries are on the rise. They're more common than non-iatrogenic. They carry a higher mortality, and they can be prevented by following systematic clinical pathway guidelines and trying to understand what people do under pressure. Thank you very much.
Thank you, Dr. Assam, for your excellent presentation as usual. And now I would like to call Dr. Amr Nour for speaking about management of the vascular pedicle in neck injury, zone 2 and 3 toward protocol.
Good evening and thank you. The neck and face are an area of superficial major vascular structures, and at the same time the neck is a zone of multi-axis motion, and the arterial structures are very close, in very close proximity with the bony prominences. So traumatic cervical vascular injuries is relatively uncommon, with around 5 to 10%, with a high mortality ranging from 5 to 40%, and persistent neurological problems around 80%. This is the grading of the vascular injury regarding carotid and vertebral arteries, and shows also the stroke rate and mortality rate. Penetrating trauma of the neck, most common mechanism of the injury, either by stab wounds like by knives, gunshot wounds, bone fragments from the fracture, cervical vertebrae, and the most common arterial injury is the common carotid artery, 73%. But also other organs like digestive tracts, airway, and nerve injuries can happen. Blunt trauma, less than 0.5% of the whole body blunt trauma, more common on the internal carotid artery distally, around 90%, and the vertebral artery, less common. The main mechanism, hyperextension or hyperflexion, and rotational motion, and also assault by direct blows. Indicators during examination of the patient regarding the vascular injury include the mechanism of the injury, as I mentioned before, hyperextension or flexion, blood loss at the scene if it is a large amount of blood loss, vital signs with hypotension, physical examination of the patient, and high-risk fractures, cervical fractures mainly. As we know, hard signs, soft signs, but also an indication for acceleration or immediate transfer of the patient to the theater is the combination of hard signs and other signs indicative of digestive or of respiratory injuries like dysphonia or voice changes, hemoptysis, dysphagia, odynophagia, or hematemesis. Blunt trauma can result in rupture or intimal tear, and both can end with hematoma, pseudoaneurysms, thrombosis, or dissection. The assessment and the management of the penetrating neck injury was traditionally centered on the anatomical zone-based classification, and this was first described by Monson and colleagues in 1969. The actual classification of the neck zones was changed slightly later on, including the well-known 3 zones of neck and the susceptible blood vessels injury in each zone. The military conflict have already improved or given experience regarding the management of the vascular injuries or penetrating vascular injuries, and the first case that was recorded for a carotid artery ligation, and actually that saves the life of a French soldier, it was in early 1522, and reported in the World War I that around 128 cases was treated by ligation, but this was resulted in reversible neurological deficit and high mortality, high incidence of high mortality. After that, in other studies between 1956 and 1969, there was some in Vietnam War. It was immediate exposure for all penetrating neck injury was the way of the management, until in the same year, 1969, the zone-based algorithm came by Monson and the colleagues. But there's some limitation regarding the zone-based approach. One of them is a poor correlation between the external skin defect and the internal injuries, and also the multiple injuries in different zones, the high rate of non-therapeutic intervention with missed injuries and the increased length of hospital stay. This lead to the no-zone concept. Classification or guidelines, sorry. There is Western Trauma Association and the East Eastern Association for the Surgery and the Trauma. For the Western Trauma Association, they have the algorithm for penetrating neck injury, and as you can see, regarding zone 2 and zone 3, if there is symptoms, directly to the theater. If there is no symptoms, you can do a CT angiogram. The East guidelines also shows that there is equivalent diagnostic accuracy between the selective operative management and the mandatory exploration for penetrating neck injuries. And they recommend the CT angiogram whose high resolution is appropriate for the diagnosis. For a blunt trauma, the same, the WT Association, they have the algorithm for the blunt cerebrovascular injuries, and the East recommendation was mainly regarding the high risk or low risk cervical spine injuries. One of the cases that was done last year, he's a 37 years old that he attacked at home with a knife in the neck, and the wound injury was exactly at the angle of the mandible. He was hemodynamically stable in the emergency department, but he has a past medical history of unprovoked PE, and he was on medication, the rivaroxaban, that we already consulted the hematology, and he was given the antidote for this. His CT shows there is a tear in the left internal carotid artery just above the level of the bifurcation with a large pseudoaneurysm, and there's a possibility of an AV fistula formation because the early contrast filling in the anterior jugular vein. The patient, we took the patient to the theater and we have an exploration, and for that we have also the exposure was a little bit different from the standard anterior superior and sternemastoid muscle approach, and we have the subplatysmal approach associated with the anterior border of sternocleidomastoid muscle, and this gives us better exposure because of the large hematoma and the better control once we entered the hematoma with the bleeding with some manual compression on the tear in the internal carotid artery. And at that time, we found complete transection of the internal jugular vein. We got some difficulty to get the distal or the proximal part of the internal jugular vein, but at the end, we ligated both ends of the internal jugular vein. This is more clear picture about the tear in the internal carotid artery. We got the great saphenous vein harvested, part of it, and using over the Berwick-O'Hara shunt, we started the anastomosis in the distal part, as you can see here, and then we have at the end the interposition graft. Post-operative, the patient has a CT and MRI, and it shows occipital loop infarction. The stroke team feels that it's more in the occipital loop, not on the carotid territory, which is most likely due to the hypoperfusion or a vasospasm. Post-op, he was managed in the ICUs and transferred to the normal ward. Stroke and hematology team review regarding MTT, regarding the anticoagulation or antiplatelet post-operative, that he after that went home in a good condition with no any complication after the surgery. Thank you.
Thank you very much, Professor Nour. Great presentation. Next speaker, our colleague, Professor Irelan from other university, to present duplex guided endovascular stenting for traumatic